All right, guys. So here is the mannequin we're going to be using for the assessment. Um, Please pay special attention when you arrive on scene of your call, that you're getting all of that information so you have a general idea of where you might want to focus your initial primary assessment areas at. Again, there's no penalty for asking for more information. We want you guys to have all that information so nobody flies blind going into these assessments. All right. So as you approach your patient, and as you've already asked for your additional resources and your number of patients, et cetera, you immediately want to have one of your partners come over here and grab manual C-spine. That has to be done because if you have to open up this airway, you might manipulate that C-spine a little bit, so we want to make sure that we're protecting it as quickly as we can. So you come down to my patient's side. I'm scanning my patient as I approach my patient. Do I see any life-threatening or obvious trauma or bleeding? It's a yes or no question. If the answer is yes, get specifics on what you see or if you can see where it's coming from. If no, then you could proceed right into your airway breathing and circulation. All right. Remember, if you do notice a life-threatening bleed right away, we want to make sure that we put that at the top of our list. Right then, right there, we want to make sure we keep all the blood in the body as much as we can. All right. So I'm going to go ahead and go up to my airway. I'm looking at my patient's airway. I'm looking in my patient's airway. I'm looking for patency at this point. Not necessarily worried about breathing yet, but I want to be able to look into my patient's mouth and nose and see that it is clear and not obstructed. We are looking for obstructions, foreign bodies, teeth, part of the tongue, blood, vomit. I'm listening to see or hear, if I can hear any gurgling, loud, snorous respirations. Those are all indicators that we have some sort of foreign body airway obstruction, or partial airway obstruction. So we want to make sure that we not just look, but we listen as well. So I'm looking in the airway for any of those issues. If I feel like I don't need to do anything at this point, then I feel free, I can move on down to my breathing. Or I might be able to say, you know what, my patient's unconscious, my patient's unresponsive. Let's go ahead and drop in an airway adjunct. Does my patient tolerate an OPA? If they do, fantastic. Is my patient breathing? All right. And what I mean by that is not just do I have rise and fall of the chest, I'm looking to see the rate, rhythm, and quality of those respirations. All right. How many times a minute is my patient breathing? Does the quality of those respirations look like it's labored? Are they fatigued? Are they sporadic? All right. If those answers come back and they lead you into needing to provide your patient with oxygen, then decide on what it's going to be. A non-rebreather? Do they just need some supplemental oxygen? Or do I need to go ahead and apply a BVM to assist with their ventilations? All right. Good rule of thumb. If during your airway assessment you have inserted an adjunct, an NPA or an OPA, preferably an OPA, then you're probably going to have to bag your patient. So just keep that in mind. They typically go together. Other way around, if you decide to bag your patient, ask yourself if you've inserted an OPA. There's no penalty to go back, say, hey, you know what? I'm going to go ahead and drop in an OPA while I assist my patient with their ventilations. So I'm providing oxygen on somebody who needs it, whether it be by BVM or whether it be by non-rebreather, again, if they need it. Then I'm just going to go right into my circulation. I've already assessed for bleeding. If I don't see any bleeding, I'm going to look at this patient's skin. All right, how is my skin presenting? If your patient is hypotensive, if they are hemodynamically unstable, this skin is going to tell us first and foremost that we have some sort of hemodynamic indicator that we need to pay attention to. Cool, pale, and diaphoretic, very, very classic signs of somebody who is in shock. So if you hear those words, your patient's skin is cool, pale, and diaphoretic, light bulbs and bells should be going off in your head saying that sounds like shock. All right. So look at that skin. Feel your patient's radial pulse. Do they have a radial pulse? All right. Remember, if the patient has a blood pressure of 80 or better, then we should be able to feel a radial pulse. If no radial pulse is present and we have poor skin conditions, that might lead us in to say, you know what, we have enough stuff here to say that my patient has a blood pressure that is pretty low. I'm already thinking shock before. Now I have every reason in the world to think that my patient is shocky. Let's go forward with that. But we do have to find a pulse. Just because they don't have a radial pulse doesn't mean they don't have a pulse anywhere else. Core pulses in your inguinal or your femoral, or right here at your carotid, we need to make sure that we document where their heart rate is. Patients who are tachycardic, which means they have a heart rate over 100, typically are dealing with some sort of inadequate perfusion. So we want to make sure we pay attention to those telltale signs as well. All right. Other than any bleeding, because we've addressed that already, we have now rifled our way through airway, breathing, and circulation. This needs to be done quickly. All right. Get the data for the airway, make an adjustment if necessary. Get the data for the breathing, make an adjustment if necessary. And for circulation, make an adjustment as necessary or if necessary. Please never skip an intervention that will improve your patient's airway, breathing, or circulation for any other reason at all. All right? So my patient's not breathing, I'm going to assist them with their ventilations. Versus my patient's not breathing, well, what does their skin look like? You've already skipped over a critical area that needed to be addressed the very minute that you found it. Okay? Please remember also, as you're approaching your patient, all right, as you're approaching your patient, am I making eye contact with my patient? Does my patient see me, see them? Are we having a moment? Do we have this interconnection? Or are they not paying attention to you? Are their eyes closed? Does it spur you to have to say, sir, can you hear me, before you touch your patient? To see if they're alert to your verbal stimulus. If they still have their eyes closed and they don't pay attention to your presence or your voice, then we do have to apply a little bit of appropriate painful stimulus to see if we can get our patient to respond. Remember our AVPU, alert, verbal, pain, and unresponsive. Vital that we get that early on in our primary exam, okay? So again, is my patient looking at me? Sir, can you hear me? Still nothing. Sir, can you hear me? Or is your patient completely unresponsive? Okay? So there is our steps for a primary exam. All right? After our primary exam, we need to make that critical decision on whether or not our patient is going to be a load and go, or if we have some time to stay on scene, maybe we haven't uncovered enough and we're not really understanding what might be going on with the patient, we've decided to stay and play. Some signs of somebody who is sort of stable. The skin is not cool, pale, and diaphoretic. You're not assisting your patient with ventilations. They have a good, strong radial pulse, which leads you to believe that they have a good, strong blood pressure. But maybe you're confused about a way that they were injured, or the way that their mental status is presenting to you. So maybe you decide, I'm going to maybe see what's going on here, decide to stay and play. All right? Again, a very, 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 very pivotal benchmark in your assessment. Finding out whether or not your patient's a load and go or a stay and play. Put that patient on a board, get that patient in the stretcher, get that patient on the way to the hospital if your patient is a load and go. All right? Now, before we go ahead and do our load and go on our patient, we just want to do a really quick rapid scan of our patient. All right? We're looking for additional injuries, any obvious life breaks, decap, BTLS, deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. Make sure we do a really, 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 really quick scan looking for those things. Please do not take your time. That's what the secondary is for. Before we move our patient onto a backboard. For instance, if your patient has a broken pelvis and we decide to roll our patient onto a backboard, we can cause further injury. So just by doing a quick hands-on all the way down your patient, feeling their arms, feeling their legs, feeling their belly, their abdomen, and their pelvis, we'll find anything that's major, okay? So please keep that in mind. Some people call it a rapid scan. Some people call it a rapid wipe down. It's whatever you want. But it's a really, really good idea to make sure that we do that before we get our patient moved onto a backboard, okay? So once we've verbalized our patient is a load and go, once we've done our rapid scan, once we've log rolled our patient, swept that back, looking for decap, ETLS, got that collar on, of course, patient's on the board, fully C-spine and immobilized, we are on the stretcher, we are going towards the hospital, it is now a good opportunity for us to reassess and start our secondary exam. And what I mean by reassess, if you started bagging your patient because they were hypoxic and their O2 sats were low, then you might say, well, we've been bagging our patient with an OPA for about 3 to 4 minutes. How is our patient presenting now? O2 sats have come up to 96. O2 sats are down to 86. Patient is still cyanotic. Patient still showing signs of hypoxia. Patient's skin color has improved. So we want to make sure that we're looking to reassess those life threats. Very, very, very sorry about that, but I'm not starting the video over. All right, so we've reassessed our life threats. Maybe we've done a life-threatening bleed. Maybe we've applied a tourniquet. So maybe we're reassessing to see how well that bleeding is controlled. We might have to intervene some more because the blood is still coming. So we might have to apply another tourniquet, some more direct pressure, whatever the case may be. So reassess those life-threatening interventions at this juncture, okay? So once we've got those knocked out and out of the way, once we've got our patient fully C-spine immobilized on the backboard, on the stretcher, on the way to the hospital, we can go ahead and do our secondary exam. If you are able to acquire a sample history, please do so. We don't really emphasize too much on the sample history during our trauma scenarios. It's more for our medical scenarios, but it is worthy of a point during your testing sheet, so it's good to ask if anybody knows the patient. Maybe we look for medical alert bracelets, check out the patient's wallet, see if they have any ID cards in there that might lead to uncovering some sort of medical condition, but we do want to make sure that we at least try to inquire about whether or not our patient has any sample history, okay? Now, I already said before, DCAT BTLS, so the main things that we're going to be looking for, and it's a head to toe, so guess where we're going to start? Right here at the head, all right? So make sure you got on your PPEs. I'm looking, I'm feeling, I'm touching the head. I'm looking for any DCAT BTLS. I'm looking in the eyes to see if my pupils are equal and reactive. I'm looking in the nose, the mouth, in the ears. I'm looking for any drainage, any blood, any clear fluid. That might be cerebral spinal fluid. All over the head, getting my hands behind the patient, seeing if I have blood on my gloves when I palpate the back of my patient's head. And move on down to the neck, all right? Looking to make sure that that trachea is midline. Make sure that my patient's neck veins are flat so we do not see JVD, jugular vein distension. Come on down to my patient's clavicles. Want to make sure that they are stable. And then right into the chest wall. All right, so again, big time looking for DCAT BTLS here. We also want to make sure we have good equal rise and fall of the chest, no paradoxical motion like a flail segment. We want to make sure that both sides are going up and down at the same time, not just one side versus the other. And we want to then listen to lung sounds, okay? After we move down from the chest, abdomen, palpating all 4 quadrants, making sure that it is soft, non-tender. Come down to the pelvis, give a gentle squeeze in and down to make sure that it is stable. And then we're just going to sweep down both legs, looking for DCAT BTLS, looking for DCAT BTLS. If your patient is able to obey commands, it's okay to ask them, hey sir, can you wiggle your toes? Can you tell me which foot I'm touching? You're checking some capillary refills, so you're checking that distal circulation, sensory, and motor. Again, if your patient is cognitive enough to obey those commands, really, really good idea to knock that out as well. After we're done with our legs and our feet, come on up to our hands, our arms, excuse me. Same thing, both hands, DCAT BTLS, check pulses, make sure that they are present. If we haven't checked the back yet, say you forgot to check the back when you put your patient on the backboard, there is no penalty to you in a mock scenario if you didn't check your patient's back prior to getting them on the backboard. It is completely okay for you to say, when I put my patient on the backboard, I would have checked my patient's back, looking for any DCAT BTLS, step off, trauma, whatever verbiage you choose to use. So either at that first juncture or at this juncture, it's completely fine, all right? If the injury you believe is on the back, hopefully you've addressed that already. You looked at it during your primary exam to see if your patient was indeed bleeding or becoming hypoxic due to some sort of chest wall injury that happened posteriorly. So just keep that in mind when we are doing the back. All right. Once we are done with our secondary head-to-toe exam, it is just time to reassess. Let's get some vitals. Let's reassess all of our treatment plans. Hopefully our patient is getting better. If your patient is not getting better, then that means we've most likely missed something. Roll right back into it. All right, I'm going to check my airway breathing and my circulation, checking my interventions. I'm going to do another detailed physical exam, okay? One other thing, guys, before we start these physical exams, these head-to-toe exams, we want to make sure that we take the time to expose our patient. If you don't expose your patient initially during walk-up or during your primary exam, it is okay, but we want to make sure that we at least strip and clip, expose our patients at least prior to doing our secondary detailed head-to-toe, all right? One last thing I'm going to tell you, please do not delay transport. Please do not delay transport. I'm going to say it twice. In order to do a secondary exam, okay? So if you do notice that your patient has a life threat, airway, breathing, or circulation is in danger, and you decide to do a secondary head-to-toe, time-consuming exam prior to making your patient a load and go, you could quite possibly fall into that failure criteria, okay? So be very vigilant, digest that data. If you have questions about what you were told or about what you see, or if you need something repeated to you, it is completely okay. We want to make sure that you guys have everything that you need so that you can make an informed decision about what you're going to do for your patient, okay? Hope this helps. Good luck, guys.